Good evening, colleagues, and welcome once more to our weekly webinars hosted by Phoenix Health Group. We are excited once more to be hosting you. And tonight's a special evening. But before then, let me just see, I see there's still more people coming in, Kamu.
Hi, Dr. Bila. Yes, some more people are still joining us.
So you let me know when.
Thank you. I think we can start.
Okay, thank you very much, Kamu, and good evening, colleagues. And that's what I was saying to those who were listening to me much earlier. Just want to say welcome once more to our weekly webinars. And please note that, as usual, these webinars are streamed live on YouTube. This is to assist you to be able to access the previous recordings for these webinars on YouTube. You can get the audio, the video, and also the slides will come as you watch it on YouTube. And I know that some of you would also want to have the slides, presentations sent to you. While we'll always check with our speakers if that is okay, but most of them have requested that we do not share the power. Because sometimes people use these slides for their own purposes after taking what the speakers have spent hours and hours preparing the presentations. But also note that these webinars are open to all colleagues from the healthcare fraternity, the medical practitioners registered, or healthcare practitioners registered with the Health Professions Council or nursing colleagues from the South African Nursing Council, and also the pharmacists from Pharmacy Council and our colleagues from the Allied Health Professions Council. You're all welcome to be part of this webinars. And we know that, especially for those from the HPCSA, you all want to get CPD points, and we upload these CPD points and send them to the HPCSA, and you get points allocated to you. You won't get certificates direct from us, but you get the points allocated to you on the HPCSA website, or you can ask for that directly. And make sure that you also provide us with your full names, your registration number, whether the HPCSA Nursing Council or Pharmacy Council or Allied Health Professions Council, and also your email address and cell phone number. In case you have challenges, please do not hesitate to contact us at webinars@clinic.co.za so that we can assist you with your CPD points, or you can send to me directly to rbila@clinics.co.za. This evening, it's a special webinar for nurses or colleagues in the nursing fraternity as we celebrate Nurses Day, which is on Sunday. Nurses Day is on Sunday, 12th May. But we have decided that we'll celebrate it this evening, this Thursday, 9th of May 2024. And within Clinics group, tomorrow there'll be events across all the hospitals. Now take it, the other groups will be doing the same thing, and colleagues in the public sector. The theme for this year, as you can see from the screen, is for this year, it's our nurses, our future, the economic power of care. So this is what we'll be talking about. And what a pleasure this evening to welcome for the first time on these webinars, someone who's been well known to most of you, I take it, in nursing especially, and also in academia, who should have known Professor Judith. She's also a member of the Clinics Heroes Committee, just newly joined us earlier this year. And Professor Bruce is a professional nurse, a general nurse, and specialist nurse educator with more than 35 years experience. The CV is there that we've shared with you, working both in clinical nursing and higher education, and she's the Vice President of the Academy of Nursing in South Africa and a Fellow of the American Academy of Nursing. And she has gained local, regional, and global prominence in advancing nursing education, practice as a vehicle for sustainable change and improvement of healthcare systems, and as a former head of the nursing education, nursing dean, teaching and learning at Wits University, Faculty of Health Sciences. She was responsible for leading progressive learning strategies and overseeing academic program qualities. And she obtained a Bachelor of Nursing from the University of the Western Cape and a master's degree from with distinction and a PhD from Wits University. So it's a pleasure to welcome Professor Bruce in our midst this evening, and she'll be sharing her thoughts with us on the power of nursing care, constraints and commendations. And welcome, Professor Bruce. It's an honor to have you in our midst this evening. Thank you.
Thank you, Dr. Bila, and thank you, colleagues. Can I just check if I'm audible?
Yes, you are.
Cool. Thank you for the invitation. I really
check
am
if the screen moves.
I'm really quite humbled to be able to be here this evening and speak to you about a very serious topic around our nurses, our future, and the economic power of care. So I hope I see there's 254 participants, and I hope that they are mostly nurses. So welcome, everyone. Right, so now there we go. So colleagues, this evening, just by way of setting the scene, I will extract salient points from the ICN slogan, "Our Nurses, Our Future, the Economic Power of Care." I will then also look at the ICN Charter of what is it called now? Charter of Change. And I would like to contextualize the ICN policy actions that they recommend for government and for employers. In particular, I'll be looking at the support and well-being of nurses, safe and healthy work environments, retention and compensation, the quality, a high quality and accredited nurse education programs, and then also government's role in managing or dealing with vulnerable populations, particularly in respect of their rights and social justice issues. The last part of my talk will be more precisely about the power of care, and this is really from the heart and specifically dedicated to the nurses on the call. Now, since this is a very serious presentation, I thought I'll start off with this slide in celebrating International Nurses Day. Now, in a virtual environment, it's very unclear how people receive this, but nonetheless, I thought this was quite a funny slide. So through its Charter for Change, the ICN has chosen to focus International Nurses Day in 2024 on the economic power of care, aiming to reshape perceptions of nursing and to demonstrate how strategic investment in nursing brings considerable economic and societal benefits. Now, according to the incumbent president of the ICN, nursing often faces huge financial constraints and societal undervaluation, despite being the backbone of healthcare. Now, significant and ongoing underinvestment in nursing has reduced this very powerful motto to a mere cliche. Now, by way of illustration, I like to show this to people. If you imagine that's the backbone, my view is that is the investment and the attention that nursing gets, and that has to change, and that is the whole idea around the ICN's Charter for Change. The economic power of care encompasses both direct and indirect contributions that nursing makes to the overall health and financial well-being of communities, regions, nations, and so forth. Now, people in need of preventive, promotive, curative, and rehabilitative care are found all over in all sorts of settings, homes, shelters, workplaces, hospitals, communities, and so forth, who in one way or another impact the country's economy. Now, we all know that the majority of people with chronic diseases, chronic ailments, disability are not found in hospitals. They live in communities. And that is where the power of nursing care should really be exerted and take effect. Now, EPC is directly linked to the quantity and quality of nurses, to how nurses are distributed, and this means both rural and urban distributions, public and private sector distributions, and also according to the different levels of the health system. And of course, the designation or the categories of nurses. We talk about skills mix. Now, in this regard, a national nursing workforce plan is absolutely essential for us to understand how this should play out in the health system. Let's focus now on the ICN's Charter for Change. Now, the whole idea around the Charter for Change is for governments to value, protect, respect, and invest in nurses to ensure a sustainable future for nursing and for healthcare. And what the ICN has done is that they've recommended 10 policy actions for government and employers. Now, in the interest of time, I'm not going to run through all 10, but I've selected ones that are critically important, and there is some overlap between these policy actions, and you'll see as we go along. So the first one is to protect and invest in the nursing profession, to rebuild health systems. And this is particularly in respect of universal health coverage, which you all know as the audience in our country. It's the NHI, which is a funding model to try and get people in South Africa to access healthcare more equitably, and also in respect of attaining the Sustainable Development Goals, particularly around health. Governments are also implored to improve support for nurses, being nurses, and this is to ensure safe and healthy working environments. Thirdly, advanced strategies to recruit and retain nurses. I won't emphasize that too much, but I will talk about improving compensation. Number 4, governments are implored to develop and implement and finance national nursing workforce plans. I think in our country, we're all too familiar with excellent plans being developed, some being implemented, but not adequate funding to support the rollout of such plans. There's also a high need to invest in high quality, accredited nursing education programs. Also, the enablement of nurses to work to the full extent of their scope of practice. And in that vein, then, recognizing and valuing nursing's knowledge, attribute, skills, and expertise. Governments are also implored to meaningfully engage with national nursing associations. If we really wanted change to happen in nursing, I think that is a very important one, but we won't discuss that in any amount of detail this evening. Number 9, place nursing ethics at the center of health systems by governments seriously protecting vulnerable populations and upholding their rights to care and, of course, people's dignity. And lastly, appoint nurse leaders in executive position and strengthen and build nursing leadership capacity. So protecting and investing in the nursing profession means recognizing and valuing health and healthcare as an investment and not a cost. By the same token, recognizing nurses as vital for effective and responsive health systems. Thus, investing in the nursing profession contributes to a positive cost-benefit analysis. In other words, the benefit that nursing brings should outweigh the costs of funding and putting nursing on the correct stand. Strategic and appropriate healthcare spending is thus an absolute necessity. And in this regard, we will look at just very quickly at healthcare spending. You can see there hospital services, 61%, public health, I think 33%, and paramedical, 4%. Now, paramedical includes all those what we would call allied health services rendered by OTs, physios, nurses, midwives, and so forth. And by the way, this includes operating costs at clinics where nursing and midwifery services in particular are offered. Now, depending who you speak to, the clinicians and the people in primary health care will say too little. Government spending is devoted to primary health care, and hospital services, clinicians, administrators, practitioners will say too little is then spent on hospital services. So colleagues, again, this needs to be looked at very carefully, but the general discourse is that too little investment is at the level of primary health care. Now, if one looks at the nursing posts and ratios, regrettably, posts have become, particularly nursing posts, have become the object of cost saving, resulting in fewer posts for registered nurses and other categories of nurses, and also community service nurses. I'm aware that in many provinces, the universities and colleges produce nurses, and once they graduate, there are not enough community service posts. And then we sit with a situation that's been in the media where you find unemployed doctors. This also leads to an accumulation of unemployed nurses in the country. Now, of the more than 33,000 vacancies across the public and private sector, more than half is in the RN category. Now, if you put into that the more than 20,000, I think, medical specialist posts, you can see that we're in a really dire situation when it comes to the post structure in our health services. Now, nurse availability and these shortages really cause us to have low nurse population ratios, which I try to illustrate with this slide. So here you see in the dark, the black short little bar there, South Africa in 2020 had one nurse per 1,000 inhabitants. So this is per population. And I looked at other BRICS countries as well. We just, with Brazil just a little ahead of us by 1.6. In between Brazil and China, there would be India at about 1.95, if I remember correctly, and China at 3.5. Now by the way, all these countries are considered as upper middle income countries. By comparison to the US and Finland at 11.9 and 18.9 nurse to population. Now, in respect of improving support for nurses' well-being by creating healthy and safe work environments, there are two key aspects that stand out. The one is safe staffing levels, that's both in terms of numbers and categories, and also protection against hazards in the workplace, and of course, workplace violence. If we look at staffing levels, these were the recommended ratios in 2013, and I am speaking under correction, but as far as I recall, there's been no further recommended ratios. Even if there were ratios recommended, it is doubtful that these are held up in various health facilities. So, for example, for every 5 enrolled nursing assistants and ENs, institutions would require 1 registered nurse/midwife. When one looks at the workplace situation, regrettably, there's been a global increase in the prevalence of workplace violence to the tune of 46 to 67%. Nurses are subjected mostly to verbal abuse, followed by physical violence. Now, in South Africa, there aren't definitive statistics, but if one just follows the media and listen to nurses' stories, doesn't matter where they practice, whether they're student nurses or qualified nurses, the exposure to interprofessional violence is also becoming quite high, and that is very concerning. 95% of student nurses, for example, in a recent study indicated that they experience interprofessional violence in the workplace. And that is, as I say, quite concerning. Lastly, to improve the support for nurses' well-being, the ICN recommends that governments, together with their other strategies, employ the World Health Organization and the International Labour Organization guidelines, including local nursing unions, to mitigate risks against workplace violence. Now, in the nursing fraternity, we speak about positive practice environments, which indicates a real nice, healthy, safe environment to work in. And what does that entail? It entails readily available nursing resources for optimal care and patient safety. We also require upgraded and modernized work environments, care environments. And I think one of the good places to start is to get rid of all those paper-based records that nurses have to deal with day in and day out. And I'm aware that some private sector facilities have already started with electronic health records and also getting nurses to record data on iPads or other forms of held hand devices. There needs to be a strengthened collegiality in our institutions, a stronger sense of professionalism and interprofessional relationships. I think that will go a really long way to understand the value that nurses bring to the health team. There ought to be appropriate support and oversight systems. A nurse should never feel that she's alone. He or she is alone in cases of dire situations. There needs to be clear lines of communication. The less onerous, the better, so that they feel supported and that any oversight that they receive are fair and appropriate. Now, the last two I colored in green because they're a little frivolous, but I think they're very serious. If you imagine yourself as a nurse who works long hours, long shifts, on your feet for a long time, that kind of exposure is very physically demanding and emotionally and mentally draining. And nurses do need adequate pause and rest spaces in their places of work. And I'm not talking about the nurse's station. That is not a resting place. But we do need nurses to have outside of the ward or the unit or the entity where the nurse works, at least a place where she can enjoy a cup of tea, debrief, and feel refreshed to take on the next part of the shift. Similarly, nurses' residences have lost their purpose. I'm not sure what is going on anymore, but that certainly has taken away the welfare that government has previously had for nurses. So purposeful use of nurses' residence needs to be reinstated. I want to continue with healthy and safe working environments by focusing for a moment on the nurses' level of education. And these are evidence-based findings that institutions that employ a higher number of registered nurses can be, I won't say assured, but there's evidence that there's a 3 to 12% reduction in adverse patient outcomes. For medical patients, there are fewer instances of adverse events, such as UTIs, pneumonia, GI bleeding, and shock and cardiac arrest. In surgical patients, again, lower rates of infection and lower rates of failure to rescue. In the ICU context, there's a reduction in the incidence of falls with every 1 additional RN hour added per day. Now, colleagues, there are many more of these statistics, but we won't just mention them at this moment. Now, when an RN has a bachelor's degree, that combination is associated with 8% lower risk of patients dying in hospital. And this is when your staff establishment has 20% more RNs with a bachelor's degree. When there is a 10% increase on your staff establishment of RNs with a bachelor's degree, you can anticipate a decreased 30-day mortality from 6 to 2%, and of course, a reduction in the length of the patient's stay in hospital. I must also say that in the case where an RN has a specialist qualification, it doesn't matter whether he or she has a degree or not, as it's been found that it doesn't make any difference to the patient outcomes. In terms of retention and the pay of nurses, so upholding positive practice environments means that nurses have the tools and resources that they require to effectively and safely and efficiently do their jobs. And you can see the overlap there with another policy action. There also is a requirement from governments to fund professional governance, recognition and development activities of nurses across their career trajectories. And of course, the very important one is to ensure fair, decent salaries and benefits. Now, if I had to do this presentation before 2022, I would have had a critique against nurses not being on the critical skills list, but rather late than never, and it's a commendation that from 2022, nurses have been included in the critical skills list. Now, look at this salary trajectory, and this is from the Human Resources for Health Plan 2030. Now, it gives a projection of what professional nurses would earn from 2019 to 2030. Look at the salaries of occupational therapist and oral hygienist. By 2030, these categories will continue to earn more than professional nurses. Ambulance workers, as you can see there, they would have caught up by next year with professional nurses and then earn more or less the same by 2030. Now, colleagues, this situation is just not, I won't even say sustainable. We cannot continue with this. And one of the reasons why this is happening is because there's a historical factor in how low nurses have been paid. And so what the HRH plan does is that it just continued to build on that low base. And that definitely needs to change, and we need our nursing unions here to be much stronger than what they currently are. Put into that the enrolled nurses and the nursing assistant, you see more or less where they lie, also way below what it's quite a low base for those categories of nurses as well. In investing in high quality accredited nursing education programs, this is essential so that we can prepare more, and I say new nurses, and also to advance the career development for existing nurses. Now, we all know that CPD for nurses are not yet in place, even though it's been approved and legislated a number of years ago. But I just learned recently that it's being rolled out, and this is being piloted. For institutions to develop high quality programs, we also need a curricula to be designed in such a way that institutions graduate nurses with the right skills, competencies, and confidence to respond to the ever-changing health profile that we have in this country, and of course to address the quadruple burden of disease. Now, I must say that since nursing has now been located in higher education, curriculum design is making every effort to be able to produce new nurses with these skills that are required. Career progression must be supported so that the generalist nurses can qualify and study further to become specialist or advanced nurse practitioners. What are the constraints at the moment? We all know that nursing education is funded directly from the health budget and understandably is thus not prioritized above or over health. Now, with nursing in higher education, I'm assuming that a new funding model will soon be put in place, which then will give nursing or ensure that nursing education receives the funding that it ought to receive, so that we produce and have institutions that can produce high quality nurses. Now, over time, there's been a significant decline in clinical and funding support for nurses to specialize, be it on a part-time or full-time basis. The clinical training platform, as many of you will appreciate, particularly in our public hospital sector, has shown some deterioration, and in some instances, to the extent where it's become quite undesirable as a nursing training platform. And here, I think more needs to be done to ensure that when we train undergraduate, diploma, specialist nurses, that the clinical training platform is at a level equivalent to the kind of nurse that we would like to see. There are also a limited clinical career pathways for nurses in the hospital or in the healthcare setting. I would argue that there is definitely a ceiling for nurses, and so many of those who would like to stay on but have reached the ceiling of their salary then opt to move on to other careers. Some leave nursing, some go into areas like academia, but the concern is there that we lose nurses to non-patient facing situations. And so the career pathing for nurses definitely needs attention as well. There are regulatory constraints as well. There are program design difficulties. As I've mentioned earlier, with nursing now in higher education, some of our nursing colleges have had a difficult time to design nursing programs that meet the requirements for higher education. And it's a real pity that there wasn't some sort of a transitional strategy for particularly nursing colleges and private sector nursing education institutions to support their program design. Because what this has done now, it's definitely delayed program accreditation, not just because of design difficulties, but also because of the duality of accreditation. So nursing programs and NEIs now need to be accredited by both the CHE and the South African Nursing Council. So there's undue delays. Some institutions wait 1 to 2 years before their programs are accredited. There are problematic articulation pathways. I think each institution is trying to rectify that, but generally speaking, we have thousands of legacy nurses who are from the legacy qualification who now have to find ways and opportunities to bridge the gap to get into the new qualification where they can either specialize or move up to a higher rank of a nursing category. And lastly, because of the difficulties, there are fewer accredited NEIs and subsequently a low nursing output from those NEIs. Nursing shortages threatens patients' health and patient safety. I thought I'll just put that in. Now, colleagues, if we look at the number of nurses on the South African Nursing Council register, you'll see that over a 10-year period between 2013 and 2022, there's just over 10,000 more nurses in terms of growth on the register. Now, also remember that nurses on the South African Nursing Council aren't necessarily all in practice. So it includes people like myself who've retired and others who choose to stay on the register. So this is just a sense of the number of nurses that we have. Currently, I think there's in excess of 280,000. I can't see what's behind that star there, but I'm sure it's useful information there. Nonetheless, what this tells us is that this is rather low in terms of what we require to have in this country. So if we look at particular categories, the RNs and the midwives, look what happened to the RNs produced by the 4-year diploma or degree and the RNs by bridging course. There you will see that there is more than 10% drop in the RN output. Now, if you take this statistic and you compare it with what the evidence say about employing RNs, you can see that we're not moving in the right trajectory. Midwives are even more dire. Now, these are the midwives that are produced by the 1-year course, the advanced diploma, as it is now called, or the postgraduate diploma. But previously, in 2013, it was the diploma in midwifery. Now, also bear in mind that the 4-year RN who comes out with either degree or diploma is also a midwife. So in that metric, you can add approximately 3,500 midwives as well. But the concern is the status now. And what we currently have is that if we look at, as at April 2024, the number of midwifery students approved for training across the country is just over 1,500. And that is fairly low if we want to achieve a good growth rate in midwifery. Now, this is way below 23 midwives to, let's see, I think it's 10,000 per population. The World Health Organization suggests that countries who have fewer than 23 midwives per 10,000 population are not going to be successful in their maternal health coverage. So that is rather a concern for the profession, and it should be a concern for the health system as well. So, colleagues, upholding a nursing ethics in the delivery of healthcare is absolutely essential, because when a government actually ensures that people can access healthcare that is equitable, non-discriminatory, rights-based, and people-centered, then we should not be experiencing any ethical dilemmas in delivering such care. Batho Pele must be more than just a cliche. It is the epitome of people-centered care. Now, a nurse or any other health professional ought not to feel ethically or morally conflicted if a health system puts the lives and health of people first. And this is a very important policy action for governments. The power of care in our health leadership begets the power of care in its workforce. Now, in that regard, I'm going to tone down a little bit and then go into the power of care. And this is specifically for the nurses on the webinar. This is not my slogan, but I absolutely subscribe to the slogan. Nurses are the heartbeat of healthcare. Nurses are integral to healthy and strong health systems, as the sinus rhythm is to a healthy heart. When nurses fail, the health system fails, much in the same way as a failing heart. Nurses are pace setters. They set the tone in caring and define the culture of care in the places where they work. And so I know that institutions and groups like Clinics Health go a long way to ensure that nurses are valued, and this is even more reason for them to set and continue defining the culture of care in the institutions. Nurses are thus trusted with the power to care and imbued with the power of care. To my nursing colleagues, the power of care is in your hands. Now, there's no conceptual definition of the power of care. However, there are real life stories about the power of care by nurses. And these nurses tell their stories. And I really want my nursing colleagues to go to this website and just take a moment and listen to some of these stories. They are really captivating. I want to use the last few minutes by sharing just some of my own, you won't find this in any resource, but how the expression of the power of care happens. Just for a moment, look at this scenario, and I'm wondering what's going through each of your minds. There lies a future economist, a future accountant, doctor, future nurse, and the outcomes of this baby are highly reliant on not only the pediatrician or the neonatologist, but also on the nurse who works in that unit. So this scenario needs a nurse who can be trusted. The doctor who's gotten the patient to this stage of his or her little life needs to have sufficient trust in the nurse to do the right thing, to be competent, to be vigilant, so that this baby can grow and reach its full potential. The nurse is also trusted by the institution, by the mother, and the family of this baby. So this scenario needs a nurse who can be trusted, a nurse who's caring and vigilant, a nurse who is confident and compassionate, and who is aware of his or her ability to make a difference to this little life. Now, in this scenario, we need a nurse who is an appropriately certified professional. Nothing less than an RN will do in looking after this baby, given to what we've just heard before. Ideally, it should be a specialist nurse with specialized knowledge and skills, but not only having the specialized knowledge and skills, but also to be competent in using the knowledge and skills blended with a caring attitude. When nurses own the power of care, it means seeing the person in the patient, not the patient or the disease in the bed. Seeing the person in the patient, not outside or alongside, within the patient. That is the beginnings of patient-centered approach. Owning the power of care means feeling what it feels like to be vulnerable as a person. It also means being empathetic and understanding what that individual person is going through. Owning the power of care means listening and being present during any form of interpersonal acts or actions. Knowing the difference that you can make in hope, healing, and health. Owning the power of care means speaking up or advocating for patients and the profession. If the nurse don't speak up for the profession, others will speak down to your profession. Lastly, owning the power of care means using your head, your hands, your heart in a combined fashion. One without the other weakens the power of care. In closing, colleagues, it is time for a shift in the perspective that emphasizes the economic value that nursing adds to healthcare and society as a whole. Urgent attention and targeted investment from government, employers, and nursing stakeholders is needed to avert a looming crisis in nursing that will have catastrophic effects on both public and private health facilities and the quality of health, nursing care, and patient outcomes. But it's not just incumbent on those stakeholders. Nurse agency, your own internal power, is essential to influence nursing's own advancement and its practice conditions. This is central to the power of care. Thank you, everyone. Enjoy Nurses Celebration tomorrow, I believe. We are now open for questions and comments. Thank you.
Thank you very much, Professor Bruce, for this insightful presentation on the status of nursing in the country, and that the nurses have the power, and that in terms of patient safety, we depend on nurses also, especially that picture that you depicted of that neonate, that incubator, that, you know, the doctor has done everything, but what happens to that baby? It's the nurse who stays 24/7 with that baby all the time, and that's what's going to happen. Now, staying on that particular picture or that situation, and you mentioned that it is not only a nurse practitioner that will take care of this baby, but it's a specialized nurse. In your presentation, perhaps you did depict the number of nurses trained in the country. But what about the specialized nurses? I mean, in terms of how dire is the situation in terms of the need to train more specialized nurses, both in neonatology or ICU, other ICU care or theater. You spoke about maternity midwives, but also in other specialized areas in nursing. Your comment on it? Can you hear me? Oh, you're muted. Sorry, you're muted. You're muted, Prof. You're muted. Unmute. Come, I don't know if Professor Bruce is unable to unmute herself. You can help her to unmute. She's muted. You're still muted. Kamu? Hi, Kamu. Answer,
Yeah,
can you
there
hear
we go.
me?
There we go. Yeah. Thank you.
There you are.
Yeah. No, answer. She just called.
I thought the problem is on my side.
I also
getting
tried to
worried.
unmute. Apologies, colleagues. Dr. Bila, your question was about, the specialist nurses. Look, unfortunately, we don't have a sense of exactly the number of specialist nurses we currently have. But you can imagine if the registered nurse route is the pipeline to specialization. So if we have fewer registered nurses being trained, if we have fewer institutions who can train registered nurses, then the pipeline definitely is being narrowed. The second aspect is also around the loss of, through retirement, of current specialist nurses and registered nurses in particular through natural processes. I mean, more than 50% of our nurses are over the age of 55. And so we're not producing and planning adequately to train specialist nurses. Then also the other problem is around articulation. There aren't sufficient articulation opportunities, and we also know that not all institutions have been accredited yet to offer specialist training.
When you talk about this, more institutions, you talk mainly about in the private sector, not the public.
Yeah,
or even in the
private sector, yeah. Because private sector contribution to specialist nurse training was quite considerable while we still had the legacy qualifications. And from what I understand, not just understand, if you look at the website of the South African Nursing Council, there are very, very few, if any, private sector institutions that can train specialist nurses at the moment.
Okay. You also spoke in terms of looking after nurses, that normally we speak of the surgical pause. It's the first time I hear the concept of a pause for nurses. I didn't, in that sense that you used it. But you talk about nurses need to find time to rest also. But is there a chance that if you do not have the appropriate rooms for nurses to take a break, have coffee, especially in the evenings, that the tendency might be for them to then do that pause at the nurse's desk? And how do you advise nurses then to say, don't pause at the nurse's desk, because you're doing so in front of patients, and they're looking at you, and then
yeah. Of course, I mean, the circumstances have changed quite considerably, because if you imagine a nurse gets up probably at 4 a.m. And let's assume she lives in the deep south of Johannesburg and needs to travel to Sandton to go to work. By the time she gets there, she needs to have a cup of coffee or a breakfast because she got up at an ungodly hour. And I think there's so much criticism against nurses who find themselves a resting place at the workstation and eat at the workstation. I think not only, look, I think it's an unfair criticism, particularly if there is no other place to do this. But also, I think there's a measure of unprofessionalism if we do that in front of patients, and not to talk about the hygiene and the state of state of hygiene that we
Okay. And earlier on
in our hospital wards and clinics.
Yes.
And is up.
Okay, thank you very much.
Do you want me to share? Shall I stop sharing?
My bandwidth is a bit low, yeah. Can you hear me now? Okay. Professor Langdon wants to know, do you have any South African states or studies for workplace harassment or violence? And maybe may I also add, is this nurse-to-nurse violence, or is it doctor-to-nurse or other healthcare workers to nurse violence that you're talking about?
Yeah, it's the article speaks about, and I apologize, I don't have a reference list, but I didn't want to make it too academic, but I can provide references for this. So we're talking mostly here about student nurses who obviously must be supervised by professional nurses. And they work with other categories of nurses. So from what I understand from the reading is that it is in that environment that they feel not only abused, but that there is that verbal abuse of student nurses in particular.
Okay, so it's in that context. Okay,
yeah,
thanks.
It's very contextual. It's very contextual.
Yeah, I think Prof. Langen also wants to know, do we have any, she sent me a message to say perhaps if we don't have studies for workplace violence in South Africa, maybe it's an opportunity for some research work.
I didn't dwell too much on the violence issue. I didn't want to make that too sad a topic, but it's a very real issue. But I also want to say that there's April 2024, I mentioned it during my presentation, my colleague at Northwest University, they did a study on nursing workforce issues, the quality of care and so forth. And it's just hot off the press. She sent me a copy just this morning to look at. And so it's worthwhile to also read what the findings are. They had over just under 5,000 nurses across the public and private sector, almost an even split of participants between private and public, and all 9 provinces were included. So it's quite a substantial study, and I haven't read that in detail, But I think there'll be very interesting findings around the nursing workforce and quality of care.
Yeah, that's quite interesting. Now going to salaries, you show this graph that shows the disparities between nurses and other healthcare professionals. What was surprising for me is to see that the ambulance workers tend to earn more than the nurses themselves. And
Yeah,
I
they
recall
more or less at the same level,
more or less at the same level.
And that's the projection for next year, 2025 and 2030. And what I'm just uncertain about is whether the paramedics, I almost get a sense that the paramedics are actually not included in that grouping.
Okay.
But I'm speaking under correction. But we can look at the HRH 2030 plan.
Okay, yeah. Because I recall a few years back, some of the paramedics when they are registered with the HPCSA went on strike or to demand, because I think they were saying that because they earn so little and that they have to pay high registration fees to remain registered, and sometimes some of them were not even getting employment. So that was an issue. I was surprised to see that in comparison, they seem to be earning the same salary as nurses. But you're saying that maybe it's the paramedics. These are not included in the category that you put of ambulance workers. And then related to that, Daphne Clavella says it's time the OSD occupation specific dispensation is revised. Would you say that because OSD was introduced to deal with the low salary rates, but it looks like it's not achieving its purpose.
Yeah, I think so. I don't think it's the real low base that would need that attention. But I also, and maybe there's some colleagues on the call who know a little bit more about this. I also understand in terms of labor, the country, the labor categorization. I understand that nursing is in a different labor categorization. I haven't found any information on that, but maybe somebody in the webinar knows a little bit more. And that also then confounds this whole issue of a low base and then building up for nurses to receive what they're worth.
Okay.
Dr. Bilap,
I see Professor Adams' hand is up. Yasmin?
Thank you very much. Thank you so much. Good evening, everyone. Thank you, Professor Bruce. Thank you for the talk. It was really an eye-opener. My question is related to the ideal number of midwives in an obstetric ward, and per level of care. So, I mean, I know the limiting factor really is that there are no midwives. But in terms of planning for a labor ward or an obstetric theatre, what would be the ideal ratio of midwife to patient? Thank you.
So that is a very sort of it's a difficult question to answer, because in South Africa, midwifery and nursing aren't separate professions. And so when you employ a midwife, a nurse, a registered nurse, apologies, you can almost always assume that she is also trained, or he is also trained as a midwife or accoucheur, as we call our male colleagues. Now, as far as the numbers are concerned, I can't tell you, Prof. Adam, except to say that if we look at our maternal statistics, morbidity, MMR, it's although it's coming down, the in-facility maternal mortality and morbidity is still not at an acceptable level. If we look at 2019, and I actually got it here, where it was 105 deaths per 100,000, it is now down to 88. But that is still in 2020, not now. That is still, in my view, too high a rate, and definitely is not in the range that's expected from the World Health Organization. As to the specific numbers, I'm afraid I can't answer that question.
Thanks for that question, Professor Adam. Yeah, I'm sure it's something that we need to look at if there's any more studies that you can look at. But the question is still related to what can we do to, what is being done to make more opportunities to upgrade qualifications of nurses? I know that you said it's because there is no accreditation of the nursing education institutions. Is there anything beyond that? I know that at some places there's you do your in-house training, enhancement programs for nurses within a particular institution or group or public sector entities.
So informally, there are fewer opportunities for nurses to upgrade. But for formal upgrading of your qualifications, either to specialist or if you're an enrolled nurse and wanting to become a registered nurse, the South African Nursing Council has had an agreement with the Council on Higher Education to make a special dispensation for nurses to be able to, for example, register at an institution, and even if they don't have the commensurate NQF level qualification to go to the next level, that institutions must do everything in their power to enable such nurses to go to the next level. So, for example, if you have a bridging course qualification at NQF level 6, and you want to specialize, you need to go and do midwifery first at NQF level 7 before you can specialize. So those opportunities are there, but they are fewer, and that is part of the problem. They will become more as more institutions are being accredited to offer the programs.
And the stopgap measures, like in the first world, they took nurses from South Africa, in the third world, so to speak, and Canada, US, the UK. And now they reverse, but I saw the numbers for India, they seem to be comparable to South Africa. But what are the possibilities of maybe even the Nursing Council allowing South African institutions recruiting nurses from places like India to augment the numbers that we have in the country?
Yeah. I think that question should be asked directly to the South African Nursing Council. I do know that there are certain prohibitions and that these nurses must, of course, write, as with doctors, have to write an examination, a licensing exam with the Nursing Council. But I can't answer that. I think it's important that we probably what do they say, grow our own timber, but that will take too long a time and to avert a crisis, which you could clearly see that is looming. So, and I know that certain hospital groups have been frustrated by our regulatory body because of the import of nurses from, or the desire to import nurses from India, Malaysia, and so forth. But only the regulatory body can answer that question.
Yeah, I'm taking my chances with you tonight. Yeah, there's a comment from one of the nurse colleagues, Lebohang Dlamini. He says it's very difficult to send sufficient number of nurses for specialist qualifications with the current lower number of nurses experienced by hospitals across the board, and unemployed numbers of clinicians, of nurses and doctors is very much concerning, considering the cost of the public is paying taxes on training of clinicians, and also consider the amount of litigations, the amount of money that can be paid for hiring this is far less than the amount of money is spent on litigation. So he said that maybe we should look at increasing the number of nurses, nurse specialists, and he concludes by happy Nurses Day, colleagues, on Sunday.
Yeah. So, I mean, one of the thing about nurses holding up health systems, and I'm sure the CEO of one of our big public hospitals here in Gauteng won't mind me using this example. I mean, there's desperation because in one of our biggest hospitals, we can't open an ICU because there aren't ICU nurses. And I mean, this speaks to the ratio of 1 to 2 nurses, 1 to 2 patients per nurse in an ICU, just depending on the acuity level of the patient. And this, I mean, also comes back to Prof. Adams' question. If there are 2 women in labor, you cannot imagine a midwife running between 1, 2, or 3 laboring women. So the ratios there are critical, and the opportunity to specialize has to be fast-tracked much better than what it currently is.
Yeah. And faced with that dire situation, Henry Mondere wants to know how to motivate nursing colleagues who are doing a job with none of these qualifications, specialized nurses, or willing or the will needed to do the required work in the best interest of the patients.
Yeah, sure. That's a tough one, because if you don't have the will, doesn't matter what opportunities we create, your will and your passion and your own drive needs to be there in order to fully engage and participate in the opportunities that's put ahead of you. It's a difficult one. I think unless you're internally driven and motivated and have the passion for nursing, it's difficult to see or even support people who feel demoralized. If there are external factors that demoralize nurses, then those need to be dealt with so that they can reach a different level of motivation to pursue further development.
Yeah. And one of the last questions is, how do you communicate your research findings to government? Do you share what, you're doing so much research work? Does it land on the minister's desk somehow or someone important?
Yeah, I think depending on look, you require to publish what you research, and I think nurses do publish. There is, if you get funding or permission from government to do research in their facilities, you're obliged to actually share your research findings with them, and that we do. In fact, there's now been a request from the PHC research group. They're having a conference in August, and some of us who've done research and students who've done master's and PhD research will be presenting at that forum. So, but as a general rule, we don't necessarily share the findings unless government asks for it, or you're impelled by certain conditions that they've set, or if they attend conferences where you present or read the articles that one has published.
Yeah, sure. But I suppose the government departments need to have someone scouting and checking the latest research articles published within the whatever discipline. That would be quite a helpful approach. And Donovan Miller wants to know, are there, we've discovered that there are quite a number of people who log into these webinars who are based in the rural areas, because nothing happens and there are not many opportunities. So these webinars do assist people in the rural areas. So I suppose this could be some of those people. Are the short courses or even certificate courses offered to deep rural clients interested in nursing courses? Because currently there are home-based workers in many of these rural areas. What can be offered to these colleagues in those communities?
Yeah. Yes, unfortunately, as with most things, rural communities are underserved even in this regard. So, before there were lots of outreach to community nurses, community OT rehab workers, physio rehab workers, and I don't know how much of that still happens. But I would encourage, if our rural colleagues have access to internet, reliable internet, there are many courses online that you can take at no cost to upgrade your knowledge and skills. So it need not be courses that WITS or any other institutions run and set up. There are many online opportunities for nurses to upskill themselves and to learn more about their profession, and particularly those who want to become nurses ultimately.
Thanks for that, yeah. And you in your presentation, you did indicate that some of the references you didn't share. Is it possible to share these references, including the one for salary projections?
Yes. So what I will do is I'll put an additional slide and then just put all the references. I normally do that, but for a more sort of academic presentation, I will do that certainly.
And then we will then be able to share the slides to all the participants.
Yes, but I have the same, slides are okay, but they almost meaningless without the presenter's input, because you will have noticed that I said other things in between the words and in between the lines. I have no qualms, provided that it's in a PDF and that people, if they wanted to use that they acknowledge the source, but also remember that I then also will have to acknowledge my sources in the slide. So I'll PDF it, Doc, and send it to you.
Thank you very much. Thanks for that.
Cool.
There's a colleague here who's a retired nurse, Carol Hussein, who says, retired nurse and would like to teach or mentor for no fee. Can you take them up to join you? How can they do this?
Yes, I'm also retired. I think colleges and universities need those kinds of nurses, and particularly because the regulatory body specifies the ratio of, the number of nurses that need to be supervised during their training. So there certainly would be and are those opportunities. It just depends where you are based. And of course, speak to your local training institution. Yeah, so I don't know which province the participant is from.
I'm sure. Yeah, I'm not that. We do have an academy, nursing academy within clinics, and perhaps the colleague can also get in touch with me, and we'll see maybe if we can then maybe refer them to. I know Benny is not. I don't see Benny on the line here, but I'm sure we can. Please contact us at webinars@clinics.co.za or rb@clinics.co.za. We can see how you can be of value to us as a group. Thank you very much, Professor Bruce. I see we had lots of discussions, and I was going to ask one of our colleagues, but there are some nurse managers who are logged in, so some of them are a bit shy to speak on this platform. But I just want to take this opportunity to thank you very much for joining us this evening and being part of this conversation and sharing your thoughts on nurses, which does not come quite regularly on this platform. But I think being part of the risk committee, we would always invite you to share some of these thoughts on nurses issues.
Thank you.
And on behalf of Clinics Health Group, I just want to thank you for this opportunity, and also to thank all the colleagues who've joined us, and even from the risk committee who are part of this presentations for joining us. And those who've been coming every week, thank you very much. We hope that you will join us again next week as we continue with our webinars. And thanks to Kamo and Anza, always helping to put a good presentation. And lastly, colleagues, we have a CPD meeting on Saturday at the Johannesburg Country Club. So we'd want to invite most of you who are able to join us at that venue. It's a whole day seminar. Please do join us there. We've shared these invitations with other colleagues on various platforms. But if you want to know more about this, you can contact me. But otherwise, have a good evening. Thank you very much.
Thank you. Good night.
Thank you.
Good night.